Thanks very much, Mike. This is going to be a little bit of redundancy with Brian's talk here. So I'm going to start off again with the Task 2 guidelines. And I think most of us can agree that in today's age, with all the technologies, most A, B, and C lesions can be managed with endovascular techniques. And as you saw, this quite D lesion that Andre tackled so masterfully, that a lot of these cases can be done endovascular means as well. An important caveat here is that patients who have severe calcification, who are at high risk for vessel rupture, the SVC guidelines actually recommend just proceeding directly with stent graft in that particular case. So here's a typical example of a patient with a calcified right common iliac stenosis. This was done by one of my partner's cases, and he pre-dilated with 5 millimeter balloons and put 8 millimeter stents, but then he had this really nasty perforation. So obviously this is to be avoided at all costs. So in terms of our options, we kind of went through these, but I want to just really focus and talk a little bit more about the balloon expandable covered stents. This has suddenly become kind of a crowded market. So we now have four balloon expandable stents that are available. If we compare them side by side, you can see that they're all ePTFE, and all except for the Bentley graft, which is available in Europe, are stainless steel. One thing to keep in mind, though, about the Gore VBX is that this has a heparin-coated surface to decrease the risk of thrombus, and the 11 and the 8L, these devices can actually be post-dilated to 16 millimeters. So this is a particularly welcome addition to the therapeutic armamentarium. All of these devices received approval on the basis of these registry studies, and you can see they're all pretty much similar in terms of relatively short lesion lengths, and they all really had excellent patency rates in excess of 90%, and the VBX in particular had the highest patency and freedom from TLR in the VBX Flex study, and this was a prospective multi-center single-arm study. And again, you can see that the Kaplan-Meier estimates are in excess of 94% primary patency, including Task C and D lesions where the primary patency was greater than 95%. So here's a typical example of kissing VBX stents. So the question is how to choose between balloon expandable and self-expanding. As alluded to earlier, balloon expandable stents are really quite good for patients who require a high resistive force for calcified lesions. You can deploy them very accurately. You can post-dilate them to larger diameters. And as we'll see here in a second, these covered balloon expandable stents can really help prevent plaque prolapse and exclude clot, and can actually treat the risks of rupture and distal embolization. But the important thing to remember when placing a balloon expandable covered stent is you don't want to cover the hypogastric or the IMA if possible. Self-expanding stents, their main claim to fame is that they can accommodate ectatic and aneurysmal disease with non-uniform vessel diameters. The problem, of course, is that you can't make them larger if you picked a size that was too small. And particularly if you're doing self-expanding stents at the bifurcation, they are subject to potentially crushing one another. And of course, they do require a larger sheath size. The COBEST trial again showed that for more complex lesions, there was an advantage to the covered stents. But the most recent randomized trial came from Germany. This was the ICE trial, and it actually turns out that the primary patency rates were actually higher, somewhat unexpectedly, with self-expanding stents as compared to balloon expandable stents, and the TLR rate was also statistically lower with self-expanding stents as compared to balloon expandable. So when faced with an aortoiliac bifurcation, you basically have four choices. You can just stent and displace the bifurcation cranially. You can do a so-called top hat and trouser where you put a stent in the aorta and then kissing stents into the bifurcation, or as we saw in Andre's case, parallel stents, and then the CIRAB, which is covered endovascular reconstruction of the aortic bifurcation. This is a diagram basically showing the steps to that particular procedure, basically placing a large stent and over-dilating it in the distal aorta, and then proceeding with kissing balloon expandable covered stents. And you can see from this paper in JVS from last year, quite excellent primary and secondary patency rates using this particular approach. For those patients who have a lot of thrombus, where you have both stenotic and aneurysmal disease, or a patient who's had clinical evidence of distal embolization, a stent graft, particularly the Endologix device, if it's a patient who has peripheral vascular disease that you might want to be able to preserve the bifurcation to then be able to go up and over and treat that patient's infrainguinal disease at a later date, that can be a particularly useful strategy. So I'm just going to finish up with a couple of quick cases. This is a patient in whom we used IVUS-guided balloon expandable stent to the aorta. She had previous kissing covered stents to the iliac arteries, but then presented with recurrent claudication. And you can see the stents look great, but she has this apple core lesion in the distal aorta. And we performed IVUS with the Volcano Therapeutics and documented that the aortic lumen was about 18 millimeters. And so we delivered the stent, a Palmas XD, and then proceeded to post-dilate initially with a 12, and then a 14, and then IVUS'd again and saw that we really could and needed to take it up to about a 16. And after a 16 millimeter balloon, we were able to get nice apposition and a good stent luminal expansion with exclusion of the gradient. This is a typical case, a top hat and trousers with a balloon expandable stent. This was a younger patient with relatively focal disease, and a 10 by 39 Palmas Genesis stent was placed in the aorta on a with the 12 millimeter balloon, and then went ahead and kissed with two 8 by 39 balloon expandable stents with a very nice result. This was a case of one of my colleagues who had a 62-year-old female smoker with an ulcerated lateral aortic lesion with a common iliac artery occlusion on the right. He was able to wire both of those retrograde and placed a 14 by 60 self-expanding stents, and then kissed with a couple of balloon expandable stents. But one of the potential downsides of a self-expanding stent in the aorta is, as in this particular case, where the renal arteries actually ended up being jailed by the self-expanding stent. This is an elderly lady with a lot of risk factors, with a very densely calcified, essentially subtotal occlusion of distal aorta with 100 millimeter mercury resting gradient, where we pre-dilated with an 8 millimeter balloon and then put in a 10 by 38 ICAST. And after stent deployment, a very nice result, post-dilated with a 12 millimeter device, and then we're able to get a very nice result in the end. This was a more challenging case of a right common iliac artery occlusion. And in this particular case, we elected to come from above to be able to traverse that antegrade. In this particular case, we did use a crosser, and then after getting successful access balloon angioplasty, a self-expanding stent distally, and then we finished up with kissing iliac stents, and after post-dil with 8 millimeter balloons, we're able to get a very nice result. Just another example of a calcified lesion where pre-dilated with a 5 millimeter balloon and a 10 millimeter ICAST was placed, and then as the iliac stents were being implanted, someone said, hey, wait a minute, where'd that stent go? Turns out it got pushed up. And so in this case, it was a simple matter of just putting a balloon in there and dragging it back down where it belonged, deploying it in the intended location, followed with a couple of kissing covered stents, and we're able to get a very nice result in the end. So in summary, there are similar results between balloon expandable stents and self-expanding stents, and self-expanding stents perhaps may be preferred for distal iliac lesion and for non-uniform diameters, but balloon expandable otherwise. And this CIRAB technique may be preferred over kissing self-expanding stents for bifurcation disease to minimize the height of the neocarina. And certainly for high-risk lesions, covered stents are preferred, such as with heavy calcification and CTOs. And these newer balloon expandable covered stents may be a lot more conformable and deliverable, particularly the VBX, and have better patency rates. And so I think it's appropriate to consider endovascular therapy for pretty much all A, B, and C lesions, and for the majority of most D lesion patients. Thank you.